Hello, and welcome to our Child and Adolescent Psychiatry Grand Rounds. I'm Dr. Alice Liang, the Section Chief of Child and Adolescent Psychiatry in the Edmonton Zone. We are quite excited to introduce our revamped and virtual Child and Adolescent Psychiatry Grand Rounds. We created a multidisciplinary Grand Rounds Committee with representation from child and adolescent psychiatry, family medicine, pediatrics, and allied health to develop these rounds. We also forged a partnership with the Faculty of Medicine and Dentistry Office of Lifelong Learning, or L3, to support the logistics and presentation of these rounds. And so we really look forward to hearing your feedback about these rounds, in addition to future topic suggestions. So I'm going to move on to introduce our speakers, Dr. Bev Stich and Dr. Mark Nicoll. So Dr. Bev Stich is an Edmonton child and adolescent psychiatrist with a special interest in treating high-risk, multi-problem youth with severe emotion dysregulation and/or BPD and their families. She's the physician lead and program psychiatrist for the AHS Edmonton Youth Community Support Program, or YCSP, which is an intensive DBT and trauma-informed wraparound service designed to work with these youth and families. Dr. Stich co-chairs the AHS Edmonton Zone Strategic Planning Group for Emotionally Dysregulated Children, Youth, and Families. And this group is developing recommendations to improve the continuum of care for these children and youth who present with either significant emotional dysregulation, suicidal or non-suicidal self-injurious behavior, and borderline personality disorder. Dr. Stich had provided collaborative mental health care for several years in primary care network, where she was involved with a number of children and youth with severe emotional dysregulation and/or BPD. And she is also an associate clinical professor with the University of Alberta, where one of her roles was to serve as psychotherapy coordinator for the Child and Adolescent Psychiatry Subspecialty Residency Program. So our second speaker is Dr. Mark Nicoll, who is a registered psychologist and clinical supervisor with Clinical Youth and Families, Addictions, and Mental Health. He has worked with numerous youth and families within the AHS since 2004 and currently works within Community Clinics portfolio. He is an adjunct professor in the Department of Psychiatry at the University of Alberta, as well as a supervisor for Child and Adolescent Psychiatry Subspecialty Residents. He is a member of the AHS Edmonton Zone Strategic Planning Group for emotionally dysregulated children, youth, and families also, in addition to Dr. Stich. And Dr. Nicoll has received advanced training in mentalization-based therapy for adolescents, or MBTA, EMDR, and collaborative and proactive solutions.
All right, good morning, everybody. Yes, we're figuring some things out here this morning, so thank you for your patience. Yes, want to appreciate everyone tuning in for today's talk. It's a pleasure for Dr. Stich and I to be talking on this topic. As you can see, we'll be discussing emotional dysregulation and borderline personality disorder in youth. We've done our best to try and be concise with our presentation, but we certainly ran into dilemmas about what to include, as there's so much to cover in this area. So our main disclaimer today is that we can't cover it all, but we will do our best to offer you some key information that will hopefully help you provide effective care to these youth and their families. We don't have any disclosures or conflicts of interest to report. And our learning objectives, we have three main learning objectives today. First, we're going to describe the prevalence and the clinical presentation of youth with severe emotion dysregulation, or BPD. We're also going to go over the importance of early diagnosis and intervention. Second, we're going to touch on the various evidence-based therapies for borderline personality disorder. And third, Dr. Stich is going to present some DBT-informed principles and strategies to work with these youth and their families. We also want to highlight that the Grand Rounds topic in June will have a continued focus on borderline personality disorder, but with a specific emphasis on good psychiatric management for adolescents. I want to highly encourage everyone to attend if you can. Dr. Lois Choi Kane is a world leader in this field. We're very fortunate to have her present to us. So if you can put this in your schedule for June, that would be great. Some interesting stuff. All right, we wanted to include some terminology, just so we're clear on what terms we're using. So first, we're including youth diagnosed with borderline personality disorder and youth with subthreshold BPD or severe emotional dysregulation as one category. It's a broad category. I think all of us who have worked within adolescent mental health have come across these youth. We know that there's a continuum of severity. We also know that families come in many shapes and sizes. And when we use the term families, we're thinking of parents or other primary caregivers, could be grandparents, could be foster parents. We know there's a wide range. We also have many different types of clinicians working with these youth and their families. And our hope is that this talk will have some relevance for all of you. And finally, you'll hear us talk about patients and clients, and they're the same thing, just different backgrounds. All right, so what is borderline personality disorder? It's a disorder that often begins in adolescence and can be associated with severe impairment and a significant risk of suicide. It also has significant neurobiological underpinnings and a genetic predisposition. So many of the areas of the brain have been implicated, such as impaired functioning in the amygdala and the prefrontal cortex. Now, it also presents clinically with sort of pervasive dysregulation in 5 areas of functioning. So in terms of emotional dysregulation, we often use the term superfeeler to communicate how these clients can be so sensitive to emotion. With behavioral dysregulation, we see some of the self-destructive behaviors, such as cutting or substance use, and also impulsive suicide attempts. Interpersonal dysregulation can lead to intense and unstable relationships for people. And cognitive dysregulation can involve things like dissociation and viewing the world through an all or nothing thinking lens. And then finally, clients with BPD struggle with their sense of self and can sometimes have a hard time recognizing their own feelings and their own needs. So why are we talking about BPD? I think first and foremost, we have to keep in mind how much suffering and distress these clients and their families experience. The work can also be extremely stressful for us as clinicians. The intensity of the work with these clients is high, and we can sometimes feel ineffective or helpless. I just had a situation like this a couple of weeks ago where I was thinking, my goodness, what the heck do I do here? I think when we have these feelings come up, we can have a tendency sometimes to either blame ourselves or blame the client, and neither of those options leads us anywhere helpful. BPD is also a high-risk disorder, and these are the patients that we sometimes end up taking home in our minds and worrying about, and it can be sometimes challenging for us to remain present and grounded in the face of so much dysregulation. Also, BPD is one of the most stigmatized disorders within mental health. And I'm sure we've all come across terms like manipulative, needy, clingy, and attention seeking. And I think what we're now realizing is that we didn't understand what was underlying the behaviors of these clients, and we tended to see them as purposefully misbehaving. We're hoping today to offer you some language that might get at more at the root of these behaviors we see, and which will be more client-centered at the same time. We're also talking about BPD today for a more hopeful reason, and that is because we have a number of treatments that have an evidence base for them. And there's certainly a lot more work that needs to be done in the area, but we currently, for adults and youth, we have good evidence for adults and some emerging evidence for adolescents. A quick slide on prevalence. Available data, we've got 1.4% of youth will meet diagnostic criteria for BPD by age 16. and it's pretty common within adolescent mental health settings. So we can see, in general community, 1 to 3%. In outpatient settings like our community clinics, we might have it range from 11 to 22%. And then in inpatient settings, it's even much more common, ranging between 33 to 49%. All right, on the topic of prognosis, due to time, all we can do is highlight a few findings and terms for you to think about. Now I just have to move a picture over here, and we've got remission versus recovery. So remission is when someone doesn't meet full criteria for the disorder. And we know that symptoms improve with time based on a couple of good studies. So remission rates have ranged from 60 to 88% within 4 to 10 years post-diagnosis. I know this surprised me when I first came across it, but there is some optimism to take from this, I think. Also, we know that receiving the diagnosis earlier has been associated with higher remission rates. Downside is functioning does not change as quickly. Clients can still have significant impairment, but no longer meet criteria for BPD. And one of the things we wanted to put on here that we won't go into depth, but just a question for people to think about and ponder is, what does recovery from BPD look like? So sometimes when we have our clients in front of us, we're not thinking about what things are going to look like 4 to 5 or 10 years from now, but the research says that, odds are that things can improve. All right. So a key message of research on BPD is that we do have treatments that have been shown to be effective. Reference at the bottom of this slide here is a recent meta-analysis from 2020. And we have some good studies for dialectical behavior therapy, for mentalization-based therapy, and cognitive analytic therapy. We've also included good psychiatric management for adolescents, because the adult version of this model has some evidence behind it. And we've been looking into the adolescent version for the Edmonton zone, because it has some promising aspects to it. So as I mentioned, in June, we'll be hearing more about GPMA. Now, again, we could have had a whole presentation on the treatments for BPD in adolescents, but we're just touching on it. But we do have a few thoughts. First off, quality research is still pretty limited. For the meta-analysis, they only had 7 studies that met their criteria. The studies demonstrated effectiveness in the short term, but generally by the end of the study, there weren't any differences between the treatment and the comparison groups. So that's a mixed finding. We think the good news is that the treatment, or as usual, or the comparison groups also showed improvements. And we think that's a hopeful message. So when you think about this, and when they compared DBT or MBT to a treatment as usual, or some sort of refined treatment as usual comparison group, they noticed both groups improved. So I think we can sometimes think we're more effective than we think. Also think that there's a common belief out there that the only way to help young people with these issues is by having a fully adherent DBT program or some other type of intensive and specialized service. And while we certainly need specialized services for some of these young people, we would argue that the research demonstrates that a number of these youth can be effectively served in the community. And I know through my work as a clinical supervisor, I run across stories from therapists like, yeah, things did improve. And so that provides some optimism. We also want to highlight that there have been some common factors identified in terms of effective treatment for BPD. So first off, a strong and resilient therapeutic alliance goes a long way. Second, validation is key. And if the client doesn't feel accepted and understood by the clinician, then any strategies offered are going to bounce off. And third, self-observation runs across treatments as well. So being able to observe and reflect on your own mind and experience is a key skill to develop, and it can be pretty challenging sometimes. And then a final thought around the overall challenges in this area are around scalability or implementation of effective treatment modalities. So whether it's DBT or MBT, both approaches require some significant training and investment of resources. And when you start thinking about the number of clinicians we have in the Edmonton zone, it can get pretty overwhelming in terms of training and clinical support. And so that's an area where the field overall is trying to find an approach that is both clinically and financially effective and also doable. So just a few thoughts about treatments there, and I'm going to hand it over to Dr. Stich.
Good morning, everyone. I'm so pleased to have this opportunity to join Dr. Nicoll in presenting on this topic. First, I'm going to talk about diagnostic considerations and predisposing factors. Then I will tell you about some DBT-informed principles and strategies that will help you to work effectively with your patients with BPD. I'm going to get started by giving you a moment to reflect on whether you think BPD can be diagnosed in patients who are under 18. Yes. In fact, BPD, it has been possible to diagnose BPD in youth under 18 since DSM-3 came out in 1980. We don't have time today to go into depth on the origins of this misunderstanding, but briefly, it seems to be related to some confusing statements made by earlier DSM authors that were intended to caution practitioners to think carefully before making such a serious diagnosis in adolescents. And then quite possibly the perpetuation of this misunderstanding was related to stigma associated with BPD and the earlier lack of effective evidence-based treatments. Well, now that I've clarified that the diagnosis can be made during adolescence, let's talk a bit about why its timely diagnosis is so important. It's because teens with BPD suffer so much, as do their families. And untreated BPD comes with increased risk of suicide attempts and death by suicide. Also, unrelenting crises significantly disrupt the adolescent's development, and early intervention limits the negative impact of the disorder on the adolescent's developmental trajectory. Depending on your scope of practice, you may or may not be the one to make the diagnosis of BPD. One way or the other, I thought it would be helpful to review the criteria as a way to orient you to the problems that teens with BPD suffer with. As you probably know, DSM-5 defines BPD as a pervasive pattern of instability of interpersonal relationships, self-image, and affects, and marked impulsivity, beginning by early adulthood or earlier, and present in a variety of contexts. The diagnosis is made of 5 or more criteria, of 9 criteria are met, but the cutoff of 5 is somewhat arbitrary. So for clinical purposes, if you have patients with severe dysregulation, but fewer than 5 criteria, you can conceptualize them as having subthreshold BPD. Sorry, just a moment, I'm having trouble with my slides here, sorry. Okay, so here are the diagnostic criteria. I encourage you to think of patients you are working with as I read through them to see whether these patients fit with this clinical presentation, and also to imagine what it might be like to be suffering with these challenges. So the criteria: frantic efforts to avoid real or imagined abandonment, a pattern of unstable and intense interpersonal relationships, characterized by alternating between extremes of idealization and devaluation, identity disturbance, markedly and persistently unstable self-image or sense of self, impulsivity in at least 2 areas that are potentially self-damaging. And then we'll go to the next slide. Recurrent suicidal behavior, gestures or threats, or self-mutilating behavior. Affective instability due to marked reactivity of mood, including intense episodic dysphoria, irritability, or anxiety, usually lasting a few hours and only rarely more than a few days. Chronic feelings of emptiness, inappropriate intense anger or difficulty controlling anger, and transient stress-related paranoid ideation or severe dissociative symptoms. Sorry, just a moment. There we go. Okay, so these are the diagnostic criteria. And there are they were add up to present a profile of a very significant, very severe mental health disorder, as you can see. What are the factors predisposing to BPD? First of all, temperament. Many people who go on to develop BPD were born with a difficult temperament, and they had neurobiologically based difficulties with emotional and behavioral regulation starting in infancy. Several mental health disorders present with one or more of emotional, behavioral, and cognitive dysregulation as core components. This dysregulation predisposes to developing BPD. I imagine you may be familiar with the very important work that has been done on adverse childhood experiences. This research has shown that the more ACEs the child has been exposed to, the more at risk they are of developing several physical and mental health disorders, including BPD. ACEs and also having a disordered attachment relationship negatively impact the developing regulatory systems of the brain. Okay, so now that I've given you an orientation to diagnostic considerations and predisposing factors, I'm going to move on to the third learning objective, which is to understand DBT-informed principles and strategies that will help you to work effectively with your young patients with BPD. And even though this discussion will focus on the youth, the information also applies to working with their families as well as adults with BPD. Also, I wanted to emphasize that these principles and strategies can be helpful regardless of what kind of clinician you are, and regardless of whether your work is based in mental health, family medicine, pediatrics, or another discipline. And finally, I just wanted to mention that you will hear me referring to Marsha Linehan a few times. And in case you haven't come across her name before, she is the one who developed DBT. Okay, so now I'm going to discuss these 4 core principles. The first one is the biosocial theory. It posits that a biological vulnerability to emotional dysregulation interacts with a pervasively invalidating environment to produce chronic, severe emotional dysregulation and the associated symptoms of BPD. The biosocial theory has considerable clinical utility in case conceptualization, management, and treatment, and also in providing psychoeducation about BPD to patients and their families. When talking to parents, patients, and families about the biosocial theory, we often refer to the biological predisposition as sensitive wiring, which they can easily relate to. There's more than one pathway to sensitive wiring. For example, a child born with a very difficult temperament can develop BPD without any other biological predisposing factors. And on the other hand, a child born with an easy temperament can develop BPD if exposed to ACEs and/or a disordered attachment relationship, because these have such a negative impact on the developing regulatory systems of the brain. People with sensitive wiring are biologically very vulnerable to emotional dysregulation. This shows up in 3 ways. 1, they are super feelers. Their emotions, positive and negative, are very easily triggered by both the environment around them and their internal thoughts. 2, once an emotion is triggered, it ramps up extremely quickly and becomes very intense. And 3, it stays ramped up for a long time. Then if another emotion is triggered before the original emotion recedes, super feelers experience further, even more intense escalation and dysregulation. So that's the biological part of the biosocial theory, which is severe vulnerability to emotion dysregulation. Now I'm going to talk about the social part, which is the invalidating environment. And remember, it's these 2 interacting together that lead to borderline personality disorder. An invalidating environment is one in which others repeatedly communicate that the biologically sensitive person's emotions and related thoughts and actions don't make sense, are inaccurate, are overreactions, or are annoying and unwelcome. This leads to feeling misunderstood, confused, rejected, and criticized, which triggers further emotional dysregulation. Also, the invalidating environment does not provide effective coaching and co-regulation to help the superfeeler learn to regulate their intense emotions. So who contributes to the invalidating environment? Superfeelers can end up feeling invalidated by parents, of course, but also by others they interact with, including clinicians like ourselves. And often the invalidation stems from an attempt to be helpful or to provide reassurance. Now I'm going to give you some brief examples of invalidation to help you understand what superfeelers experience. With one exception, they're all going to relate back to the same little scenario with Katie, a superfeeler, when she tells her mom she feels sad and discouraged after failing a test for which she believed she had studied enough. Remember, this is a girl with intense emotions that become escalated quickly and have a hard time returning to baseline. So this is Katie, our superfeeler. So maybe mom says, "Stop worrying. It's no big deal, honey. It's only one test." Here, mom is trying to be reassuring, but the invalidating message is, "Stop feeling the way you actually feel." Or maybe mom says, "It's your fault, Katie. If you'd studied more, you would have passed." This time, the invalidating message is, "Since it's your fault, you have no right to express feeling upset." And clearly, mom is also being critical here, which hurts Katie's feelings. Or maybe mom says, "Just study more next time and you will do great." Here, mom overstates and oversimplifies the ease of the problem solving required to meet Katie's goal. And this is the same type of invalidation embedded in Nancy Reagan's famous slogan about solving drug addiction: "Just say no to drugs," the epitome of invalidation. When this type of invalidation happens repeatedly, the superfeeler internalizes unrealistic, unachievable goals and expectations, and then feels ashamed and demoralized when they can't be met. Over time, this also leads to an internalized sense of inadequacy and worthlessness. Here's a more complicated example. Maybe mom says, "What's the big frickin' deal? It's only a test." And then she goes back to watching TV. The invalidating message is, "You're overreacting and I'm busy. Don't bother me." Katie starts sobbing and threatens to not go back to school. Mom softens and says, "Okay, let's go out for a nice dinner tonight to help you feel better, and I'll help you study next time." This time, the unintended message is, "If you get really upset, I might stop projecting your feelings and ignoring you and be really nice to you instead." And as you can see, in addition to being invalidating, this response is problematic because it also accidentally reinforces an escalation of emotional dysregulation. As you can imagine, chronic repeated invalidation leads to inability of the superfeeler to trust her own emotional experiences, confusion about herself, shame, self-criticism, a sense of worthlessness, and difficulty trusting others. Also, in an environment of invalidation, there isn't the opportunity to develop the capacity and skill for self-regulation. It's important to note that kids who are superfeelers are not destined to develop BPD. If their attachment figures are able to consistently validate and co-regulate their intense emotions, then they feel understood and accepted, and they internalize a sense of being good enough, as well as the capacity for self-regulation. In addition, superfeelers often do need coaching to learn specific skills to regulate their intense emotions. Some parents intuitively know how to provide this coaching. At other times, the child and parents may need some professional help. And that's where early identification and intervention can make such a big difference in the developmental trajectory of superfeelers. Okay, so just to very quickly summarize this first core principle, the biosocial theory posits that a biological vulnerability to emotional dysregulation interacts with an invalidating environment to produce chronic, severe emotional dysregulation and associated symptoms of BPD. Now I'm going to move on to the second core principle of DBT, which is related to the impact of change strategies on patients with BPD. Simply put, change strategies refer to any strategies that require your patient to do something different regarding their health or mental health. Here are just a few examples of change strategies that will hopefully give you a practical feel for what this principle is referring to. So change strategies in healthcare could include lifestyle counseling, working on medication adherence, asking your patient to see another service provider, such as a mental health therapist or a dietitian. And change strategies in psychotherapy could include teaching grounding, mindfulness, and DBT skills, cognitive restructuring, and exposure to anxiety triggers. And again, these are just a few of many, many possible examples. Marsha Linehan was the first one to write about how patients with BPD are exquisitely sensitive to experiencing change strategies as invalidating. She figured out that this is because change strategies remind them of many previous experiences of invalidation in which the ease of problem solving and of meeting goals was overstated and oversimplified. Also, they often experience change strategies as implicit criticism that they aren't good enough and need to improve to be acceptable. All this can trigger overwhelming feelings of shame and worthlessness and intense emotional dysregulation. Marsha Linehan realized that her patients with BPD weren't getting better because the change strategies were intensely dysregulating, and it is impossible to benefit from a change strategy in a state of intense dysregulation. At the same time, she knew that her patients needed to make changes in order to create a life worth living. This led her to develop the third core principle of DBT, which is that acceptance strategies are an essential component of working effectively with patients with BPD. Acceptance strategies make it possible for patients with BPD to be receptive to the change strategies that will lead to functional improvement. Validation is the core acceptance strategy, and I will go into more depth on validation shortly. The fourth core principle is to take a dialectical frame of reference, the D in DBT. So what does dialectics mean? Simply put, it means that two opposite ideas or truths coexist at the same time, the dialectical dilemma. And when considered together, that they can be synthesized into a new way of thinking about the situation and solving the problem. And in DBT for adolescents, this process of identifying and resolving the dialectical dilemma is called walking the middle path. Why is a dialectical frame of reference important? Patients with BPD become rigidly stuck in black and white, all or nothing thinking, especially when dysregulated. They are convinced that their truth is the only truth. A couple of common examples are, I can't stop cutting myself. It is the only way I can calm down when I'm upset. And I'm never going to have a close friend. I'm a total failure. They need help with moving towards more flexible, both and thinking. And when your patient is firmly entrenched in one truth, you will find yourself inclined to become entrenched in the polar opposite truth. Being aware of these inevitable polar opposites is the first step in solving the dialectical dilemma. And I will give you an example of this in the next section. Having a dialectical frame of reference also helps you to keep in mind the central dialectical dilemma in working with patients with BPD, which shows up over and over again. My patient needs to be accepted exactly as she is in the moment in order to avoid intense dysregulation. And my patient needs to change in order to stay safe, to benefit from care, and overall to create a life worth living. And that brings us to the end of the section on the 4 core principles of DBT. I'm going to spend the rest of the presentation discussing 6 DBT-informed steps that will promote emotion regulation, an effective clinician-patient relationship, and your patient's receptivity to change-based strategies. These steps are: be mindful, think dialectically, be validating, introduce change strategies thoughtfully, expect dysregulation in your patient in response to the change strategy, and expect dysregulation in yourself in response to your patient's dysregulation. And then as you're working with your patient, repeat these steps as indicated and try to end the appointment with validation. So step 1 is to be mindful. This involves slowing down, participating in the present moment, noticing and reflecting on your and your patient's emotions, thoughts, and urges without judgment, increasing compassion for self and others, and choosing your actions thoughtfully. Here's how you can apply mindfulness to working with your patients with BPD. Orient yourself to how you're doing. Notice if your body is feeling tense. Maybe try taking a few slow, deep breaths. Orient yourself to your patient and their disorder. Remember that your patient is a super feeler and exquisitely vulnerable to feeling invalidated and becoming dysregulated. Notice any tendency towards judgment of your patient or yourself and try to let the judgment go. Tune into your capacity for compassion for your patient and yourself. And remind yourself that staying mindful will set the stage for working effectively with your patient. The second DBT-informed step is to think dialectically. As you work with your patients, notice the dialectical dilemmas and think about how to resolve them by walking a middle path between the two opposing truths. Here's an example. If your new patient says, "I'm never going to get better no matter what you do. I've seen other therapists and I'm no better off than I was. It's hopeless." If they say that, you might think, "That's not true. I'm a really good therapist and I know I can help you. You're being so negative right now." You feel stuck and you realize that you and your patient are polarized and that both of you are engaging in black and white thinking. Then you remember to think dialectically. Well, see what he means about never being helped before. And even though I know I'm a really good therapist, can't be 100% sure that I can help him. Then you validate your patient's past experience. You say, "That must be really discouraging to have seen several therapists and never been helped. I get why you feel that seeing me won't help either, and I'm glad you told me." You make a suggestion to walk the middle path together. You say, "I do want you to know that I have lots of experience working with youth with severe emotional dysregulation or BPD, and I feel like we've made a good connection so far. You're right though, I can't absolutely guarantee that I can help you. What about if we give it a few sessions and see how it's going? Please let me know anytime if you think I'm off track or not being helpful. That way we can work together to find what fits for you." Your patient feels heard and relieved and says, "Well, I guess I can come a few more times. It can't hurt to give it a try." Okay, so moving on. Being validating is the third DBT-informed step. Validation is the core acceptance strategy of DBT, and it is a very important skill to understand and integrate into your work. Validation is the process of recognizing and empathizing with a person's thoughts, feelings, or actions, making sense of their thoughts, feelings, or actions given their life context or situation, and communicating that understanding in a way that is attuned to where the person is at in the moment. Why is validation of central importance to working with your patients with BPD? It facilitates emotion regulation, supports change strategies, strengthens communication and the clinician-patient relationship, and helps to increase the capacity for self-validation and self-confidence. As Marsha Linehan said, validation is like aspirin for emotional dysregulation. Marsha Linehan thoroughly detailed 6 ways to be validating. I know you were all taught some of these ways when you were learners, and also they make intuitive sense. I'm going to quickly summarize most of what she said about validation and then go into a bit of detail on a particular aspect that can be less intuitive. So validation includes actively listening and reflecting back what you've heard and conveying that your patient is genuinely, respectfully, non-judgmentally accepted exactly as she is in the present moment. And it includes reading between the lines. For example, your patient tells you she's fine, but her facial expression and body language say otherwise. You could say, "You're telling me you're fine, but you look kind of upset. I wonder if something is bothering you, but it's hard to talk about." Validation also includes allowing your genuine responses as a person to come across and be part of the conversation. Here's where validation can get trickier and less intuitive. Basically, sometimes it's hard to figure out what is valid about your patient's response. And it is so important to look for and communicate the validity, even when at first glance the response seems dysfunctional or illogical. You can look for elusive validity based on your patient's current context, plus or minus her history in biology. For example, where is the validity in self-harm? Well, it may be the only strategy the patient has learned so far to regulate intense negative emotions. And it works. Also, if the patient lives in an environment that only responds to demands for attention and care when she harms herself, then self-harm becomes a valid means of obtaining care in that environment. Here's a way you could validate your patient's self-harm. You could say, your cutting makes sense. You were so upset and you didn't know what else to do. And you discovered what scientists also know, that cutting actually decreases emotional pain for a little while. Note that saying, and you didn't know what else to do, is a tactful way to acknowledge a skills deficit, which helps to lay the groundwork for a change strategy. Also note that you decided not to communicate validity in terms of being a way to seek care from an invalidating environment because you determined that it wouldn't be a helpful intervention in the moment. So in summary about validation, as Blaise Aguirre wrote, the skill of validation is one that is not always intuitive, can be difficult to put into practice, and yet brings vast benefit. Okay, the fourth DBT-informed step is to introduce change thoughtfully. Be tactful, sensitive, respectful, and collaborative. And be careful not to introduce more change than you think your patient will be able to manage, given her current skills and life context. Also, don't forget to interweave the change strategy with lots of validation. As Charles Swenson wrote, working with people with BPD involves a nimble dance between acceptance and change strategies. The fifth DBT-informed step is for you to expect dysregulation in your patient in response to introducing the change strategy. Remember, your patients with BPD very often experience change strategies as confirmation that they are unacceptable, worthless, or incompetent, and this can trigger intense dysregulation. You can minimize this by introducing the change strategy thoughtfully, but some dysregulation is still to be expected. The dysregulation can manifest in many ways. Your patient could become sad. She might shut down perhaps due to shame, hopelessness, or disconnecting from you. She could go into a state of apparent competence where she thinks, I don't need any help. I can do this on my own. Or she might show anger and devaluation towards you, maybe saying, who do you think you are telling me what to do? Or I knew you didn't know how to help me, you just don't get it. Or you don't care about me, this is just a job for you, and so on. Well, the sixth DBT-informed step is to expect dysregulation in yourself in response to your patient's dysregulation. It would be natural to react to your patient's dysregulation by becoming somewhat dysregulated. As I go through these common examples of clinician dysregulation, I invite you to think of some times when they might have applied to you. And I know they've all applied to me. Maybe you felt hopeless about being able to help. Maybe you felt ineffective and self-critical. I just don't know what to do next. I'm no good at working with this kind of patient. Maybe you felt annoyed, angry, critical, or blaming to your patient. Who does she think she is talking to me like that? She is so ungrateful. I'm working hard with her and all she does is complain. She's treatment resistant, and so on. And also, you might have judged yourself for having negative thoughts and feelings. If you're expecting your own dysregulation ahead of time, you won't be caught off guard when it happens, and you will be prepared to circle back to the top of the sequence of steps. You start with being mindful. You pause, take a few breaths, Notice your judgmental thoughts towards your patient. Wait for them to pass and remind yourself of how exquisitely sensitive she is to feeling invalidated by change strategies. This helps you to find your way back to feeling compassionate towards her and to being in wise mind as you consider what is going on and what to do next. You think dialectically. For example, you might think, that dialectic between acceptance and change just showed up again. Wonder whether my change strategy expected too much of her, and that's partly why she got so dysregulated. Then you validate how upset the change strategy made her feel and check out whether she felt you were expecting too much from her. Based on her response, you assess whether she can tolerate another attempt at change. If you think you can, if you think she can, you use lots more validation as you work with her to consolidate a change-related plan of action. And finally, you try to end the appointment with validation. And speaking of validation, I want to validate how hard this work can sometimes be, and also how long it can sometimes take for our patients with BPD to find that life worth living. It takes many small steps and us walking the middle path with them all along the way. At the same time, this work can be so fulfilling and sometimes joyful. Every small step that our patients take is worth celebrating, given how incredibly difficult it can be for them to even consider making changes. Well, that brings us to the end of the presentation. Mark and I wish you all the best in your work with your young patients with emotion dysregulation and BPD, and we look forward to responding to your questions and comments.
So I think we do have a number of questions here. I think prior to starting the Q&A section, I'm going to introduce Karen Bozosha, because she's one of our panelists for this question and answer part of the workshop. And by the way, thank you so much, Dr. Stich and Dr. Nicoll, for your very informative and compassionate talk about this challenging population. So introducing Karen. So Karen Bozosha is a program manager with children's addiction and mental health. And she spent over 20 years working in the field. Currently, her portfolio includes the YCSP program, trauma treatment services, and the Stollery emergency department. And so she'll help to field questions about AHS services for these youth and their families. It looks like most of these questions. So I'm just going to start off from the top, and then I guess Dr. Stich, Dr. Nicoll, or Karen, feel free to answer as you see fit. So the first question is, oh, actually they're in this slightly. Okay, so the top one is, can you give an example to validating Katie, the super feeler? It was wonderful to read how things were invalidating, but then what response would you consider validating?
Great question. I would say something like, oh, Katie, you must be so disappointed. You studied so hard for that test and you thought you were going to do well on it. And instead you failed. That must be so hard for you. Mark, do you want to add anything to that?
No, I like it. I think there's many ways we can validate. I mean, the key formula is just to be, for the caregiver or the adult in Katie's life, to be thinking about, well, I wonder what Katie's thinking and feeling right now, and then I'm going to try and communicate that. And that's that's often how we just try and teach validation to parents as well.
I just want to add in, I think the other part that sometimes as parents and therapists we fall into is offering a solution. So I think that the key part of this is at the end of however you want to express your validation is not to follow up with, maybe you can study differently next time, maybe we can talk to the teacher, whatever that solution is on the end is stopping ourselves from going there.
That's a great
point. That's a great point, Karen. It's the, I know you feel terrible, but this way, or yeah, exactly. That's a great point, Karen. Thanks.
And I would imagine too that sometimes you would need to validate repeatedly, right? Because sometimes it's not so quick that they feel validated. Sometimes you end up doing it repeatedly.
Yes, repeatedly for the same situation, and then many times in general. These kids need validation, lots of validation.
And I think that's a key point, Alice, as well, because, when I think about the toolbox of DBT, I almost think of it like I would see about 50% of I don't know what the percentages are, but I would see about 50% of it is taken up with the validation tool. And then the other 50% is all the, whatever it is, Bev, 200 change strategies that Linehan has come up with. And I think we often end up jumping to change way too often and forgetting about that.
Yeah, and the change strategies, as we've discussed, are ineffective if the patient's not able to receive them.
Yep.
Yeah.
Okay, thank you. So moving on to our next question then. If we can work to reduce the predisposing factors or impacts of these factors, such as trauma therapy for ACEs, increasing resilience, teaching flexibility skills, can we change the trajectory and prevent BPD from being more of a lifelong diagnosis?
Bev?
I have not come across any research on this, although it may very well be there and I haven't looked for it. But clinically and logically, it makes absolute sense that when kids are presenting as being emotionally very vulnerable, if we can help them with their emotional vulnerability before they escalate to the point of developing those symptoms of BPD, yeah, I really think we can prevent the development of BPD by skilled early intervention and treating those underlying conditions or predisposing conditions, absolutely. But just a reminder that such a significant part of the intervention needs to be with the parents and other caregivers as well, including school teachers and coaches and so on. These kids are so exquisite to feeling invalidated that those around them need to learn validation skills and really understand them, embrace them, and use them.
Yeah, I think as well, like it's a complicated sort of intervention process and prevention process, but we've got research that already says it's often not a lifelong diagnosis. And so even if you meet criteria for borderline personality disorder, like 60 to 88% no longer meet it within 4 to 10 years. And that doesn't mean that things are all rosy for these clients, but we do have some treatments that are effective, and even the community treatment that's not specialized can be effective. And that's a key thing that's getting emphasized by a lot of the leaders in the research world, that we're more effective than we think.
And that's a good plug for their upcoming GPMA talk. So our next question here is an interesting one. Do you have any specific strategies for managing frequent ER presentations, and anything that you would maybe suggest in terms of family doctors, in terms of best practices with respect to emergency?
Bev, you go ahead.
Oh no, go ahead, Mark.
I think that's a great question, and I don't have many concrete answers, but I think first off, letting them know that there are effective treatments for this. So I think that's related to some of our own common beliefs within the mental health system and the health system of, oh man, we can't help this unless we can refer to this DBT program. We can treat emotional dysregulation and we can help kids with this. And then there's, I think, as being as validating as possible. Bev, what do you think?
Yeah, and I'm just wondering if part of the question is, if the question is coming from a family physician and wondering about whether there might be another option besides sending the youth to emergency if they're acutely suicidal, for example. I'm not sure if that might be part of the question. Just in case it is, Karen, I wonder if you could talk about what some resources are for kids that are intensely dysregulated besides going to the ER.
Yeah, and thanks for that, Bev. What comes to mind is reaching out to one of us, and I can be the point person on this call because I don't think that responsibility lies on the ED or the ER. I think if you reach out, we can find a therapist who has the capacity within our continuum to treat this population, and then developing a emergency plan with them that doesn't include the ED. And we've done that successfully a number of times. Like Bev and Mark mentioned in their presentation, part of the concern is that if you aren't validated in any other way, you will find validation through going to the ER. And a number of these clients, I'm going to use the word enjoy staying in an inpatient environment because they do receive that care and validation. So I'm going to say, because this is a longer answer, I'm going to say reach out. My name's on there. If you're thinking of a specific individual, they need to be wrapped. They need to learn what to do in a crisis. And then we support them in a crisis using a DBT approach. That's kind of the short answer.
Yeah, and we have crisis, the Children's Crisis Service, Karen, and the other service, I forget
The
it.
community of service,
Right.
That's it. Yeah.
Yeah.
So definitely that's a resource, and I think you would be able to contact the Stollery or U of A switchboard to if you don't, I think we could probably provide information on the phone number for the crisis team, or you could switchboard, and as needed you can escalate to the community services team. I'm noticing we're at 11:59 now. Maybe just list one last question. Do you have recommendations for validation training workshops or skills building for parents?
The first one that comes to mind is Family Connections. And it is designed exactly for helping parents or family members of people with BPD, whether they're adolescents or adults with BPD, to be able to support their loved one with BPD. And that would include teaching them teaching the family members validation skills as well as other skills. Karen, are we able to put the link to Family Connections up there as well?
I think so. And if not, we will get it sent, because I believe we're sending out
We can.
the survey, so we can send that out too.
Okay.
I'm just noticing that we have a number of questions left, and maybe L3 can help with this. If, let's say, we kept these questions on here, would the panel team be able to type some answers to at least some of these questions afterwards?
Or Alice, another option is if anybody is interested in staying on longer, and if we're all okay with that, we could stay on for another 15 minutes or so if people have.
Oh, okay. All right.
Yeah.
If that's an option, then I guess people can just log off as they see fit.
And I can't see how many people are still on the webinar.
It looks like we have 108.
Still left. Okay.
So a few are sticking around.
Okay, all right. Well, let's continue then. It seems like this is, people are wanting, to have their questions answered. So the next question is, can signs of borderline personality disorder emerge prior to adolescence? And this individual just wondering in relation to early detection and intervention.
That's a great question. And although the lower age limit of diagnosing BPD has not been stipulated, I think there's a bit of a sense that children who might not warrant the diagnosis of BPD because they haven't really developed a personality yet. There's some controversy about that from a kind of a definitional point of view, but from a symptomatic point of view, these kids, they can present in elementary school, and you can, or maybe even younger than that. These are the kids that are exquisitely emotionally vulnerable to dysregulation. And there is actually DBT for elementary school kids. It has been developed for elementary school kids. So early identification and intervention, even down to elementary school, has been looked at and is in the works. I think I don't know whether we could officially make a diagnosis of BPD in an 8-year-old. I think we'd all be a little not skeptical, but hesitant to do that. But we could certainly say borderline personality disorder features in those little kids.
Yeah, and start intervention and treatment, even with the emotion dysregulation piece and some of those traits, it sounds like.
Yeah. There's lots of things we can do for emotional dysregulation, and the younger they are, it might be the more, I don't know, general interventions can be effective, but working with parents, like I think of the Circle of Security parenting groups, just helps facilitate regulation in kids when parents are regulated and when they identify their own shark music and all those kinds of things. So I think there's a number of things that we can do to prevent and intervene at younger ages.
Right. And so from using a DBT paradigm, no matter how young the child, we can help the environment to be validating rather than invalidating. Yeah.
Okay, thank you. So the next question is, how do you consider trauma when diagnosing, as it seems a lot of predisposing factors are commonly seen for clients with severe trauma? And is there concern that someone might be diagnosed or overlooked in terms of their trauma symptoms?
Well, shall I respond to that, Mark?
Sure.
A lot of kids with BPD, I don't know the exact percentages, but it's not unusual for kids with BPD to have trauma. So either a diagnosis of PTSD and or significant developmental trauma with disordered attachment relationship, a frightening parenting figure who's their primary attachment figure. So it's in both and assessment process. It's really important to look for the pre-existing co-occurring mental health disorders, trauma being such an important one to be mindful of. That being said, kids with PTSD or other types of trauma can develop BPD as well. And it's important to keep both of those diagnoses in mind and to treat both of them. And of course, kids with BPD can also have, actually, this is really, just as a quick aside, this is a really important co-occurring disorder to always look for, which is ADHD. It's quite a common co-occurring disorder, and the impulsivity of ADHD makes the kids with BPD even more dysregulated. And if you treat the ADHD, you might see some improvement in some BPD symptoms.
The only thing I'd add to that is that, what the research is finding is that they don't always co-occur. Like that's because some people have argued that, BPD is just is a complex trauma disorder. And there is some research that it sort of, how am I going to put this? It goes both ways. So you can have people with BPD that have not experienced significant trauma because they're still super feelers, and that there's those genetic components to it. You have people that have PTSD and trauma that don't develop borderline personality disorder. So they stand on their own, but there is a significant overlap. And sometimes when you have that complex trauma in with BPD, it can be more challenging to treat.
And then one of the decision-making points is which disorder to focus on first, if you can't focus on both at the same time for some reason. And I think most of the time focusing on the destabilizing behaviors like the unrelenting crises, the suicide attempts, self-harm, and so on, with a kind of a DBT lens is the first step, while being very mindful that underlying that is it could be a severe PTSD. So, but sometimes it goes the other way around. You have to really be mindful of what the particular clinical presentation is.
Thank you. So I don't know if maybe because again, if these could be quicker answers, can DBT be applied for clients with moderate intellectual disability?
I don't know the research on that.
I don't think so, actually. I not probably not moderate.
It would be challenging. It'd be
Yeah.
really hard. Yeah.
And what is the advantage of calling, I guess, the diagnosis borderline personality disorder over, let's say, emotion dysregulation, especially with the healthcare stigma of BPD?
In my experience, the patients and their families are not aware of the stigma, and typically they are enormously relieved to have a diagnosis for what the kid has been experiencing. But so it's in and of itself, it's a relief. It's really validating to get that diagnosis, and then to also know that there are evidence-based treatments for it. So we, I think, as a professional community, maybe see the stigma, and there has been significant stigma in the past. I think in the general public as well. But these kids, I don't think they're mostly tuned into the stigma. That's maybe a too simplistic an answer, but that's been mostly my experience.
Yeah, I mean, I find that in younger people, almost like all cases, they do find it's a relief, and they feel more understood with the diagnosis, and they want a diagnosis. So it may be different for some of the older adult populations, but definitely with the younger teenage population, that's been my experience as well. So thanks for that. The next question. Thank you for the excellent presentation. While formal DBT is a predominantly outpatient treatment, can you comment on how this DBT framework would view the role of brief inpatient hospitalization in behavioral shaping for chronically suicidal individuals?
I'm not sure how brief the admission would be in order to accomplish behavioral reshaping. There are in the US 3 residential treatment programs with a DBT paradigm for kids with severe borderline personality disorder. They are really effective, or at least the one program I know well is really effective. I think there's also potentially a role for a very brief stabilization admission for kids, like 2 or 3 days when they're in the middle of a psychosocial crisis. The criteria have to be really clear for admission and discharge, and the unit needs to be set up in a way that will be helpful to these kids. So it requires a careful planning and implementation. And other than that, a lot of kids with BPD actually, as I think many of us know, tend to do worse when they're admitted to a regular inpatient unit.
I think, Bevan, correct me if I'm wrong, we've used it very sporadically and reluctantly with our population, and only with those strict boundaries, as you've suggested.
Yeah.
Thank you. Yeah, maybe this has something to do with the dialectic that you mentioned. How can one balance treatment of animal cruelty with BPD?
I'm not following on that one.
Or maybe, let's say, I presume this refers to, let's say, if an individual with BPD is engaging in animal mistreatment, and how would you, let's say, work with that?
The only thing that I can think of, and Mark and Bev jump in, when we do DBT, we also kind of have a hierarchy of things that we want to address. So the hierarchy is life-threatening behaviors and issues first, then treatment interfering behaviors, and then we get to quality of life interfering behaviors on our path to get to a life worth living. So I think the clinician would need to make a determination on what specifically that animal cruelty is and where in that sequence it lies to determine at what point are you giving it relevancy for treatment.
Yeah,
I'm not sure if that answers the question.
And also I would want to do an assessment for the possibility of conduct disorder, and if there's co-occurring conduct disorder and BPD,
yeah,
that might indicate a different kind of treatment approach.
Yeah, it would depend on how you conceptualize in your assessment process. Yeah.
All right. So one last question, and we're almost at the end. So that's after validation, at what point do you introduce change strategy using the collaborative approach?
I think that's a difficult question to answer in a protocol type way. I think it depends on exactly what's going on in the moment in the work between you and your patient. You have to read the nonverbal cues, depends on the context of what's been discussed. I think maybe one principle that would make sense would be to say that if your patient if the validation that you've provided with your patient has left them feeling more settled, more regulated, more connected, and you feel like they could tolerate then a tentative, at least step towards a change strategy, and maybe check it out with them. Like, I'm just thinking of something we might be able to do here together that might be helpful, and ask your patient if they're ready to engage basically in a change strategy, something like that. But there's so many different things that are going on in a therapy session that it's hard to give something prescriptive.
I think that principle of collaboration, that Tilda, you wrote it down there, and Bev, you just elaborated on it. It's collaborative, it's tentative. You're always watching for feedback from your client. Have I pushed them too far? Have they shut down on me? Or you're asking. So, and if they're saying, well, no, I'm going to give it a try. And you actually, as long as you're doing it in a reflective and intentional way, I think you're going to pick up on those cues on whether they're ready or not.
Right.
So I want to thank everyone who attended our inaugural revamped Grand Rounds. And, definitely we look forward to hearing your feedback, including, future topic suggestions. So thanks all, and have a great rest of your day.